Great. Maybe we should get started since it's 9:30. Wanted to welcome everyone to the Washington State Telehealth Collaborative. I'm John Sky, and we are joined here at Confluence Health Center in Wenatchee, Washington. So first, I think what we'll do is just do attendance. We'll start with folks in this room. Maybe we can start with Representative Schmidt. Sorry, I got to go too much.
Your timing is
impeccable.
Joe Schmidt, I represent the 9th District, and I'm one of the state officials on the collaborative.
Grant Truman, I'm the COO, CFO of Ferry County Public Hospital District in the Republic of Washington.
Aaron Edwards, I'm the CEO of Ferry County Public Hospital District.
Mike Surratt, I'm an optometrist with the Optometric Physicians of Washington, and just here to listen.
Ken White, a retired optometrist and representing Optometric Physicians of Washington on their behalf. And I'm also here to listen. We're impressed with what you're doing.
I'm Joshua Frank. I'm a local emergency physician. I'm here on the collaborative representing the Washington State Board of the American College of Emergency Physicians.
Jeff Clark, the internal medicine doc and CMIO for Confluence Health, and have been engaged in telehealth actually for several years and helping move our various initiatives along.
John Scott, University of Washington.
I'm the program manager for the collaborative, and I'm also the telehealth operations coordinator.
I'm Vicki Noyes, Chief Operating Officer at Confluence Health. Have been here in the Wenatchee area 4 years next month, and came here bringing with me a passion of telehealth when I came from Arizona, and trying to help our organization progress with telehealth services. And we have made some progress that probably Craig will talk a little bit more about, but have a lot to learn and a lot more progress to make. So thanks for having it here, and thanks for inviting us.
Thanks for letting us have here.
My name is Ray Hanley. I'm a manager at Labor and Industries. I run payment policy there. I'm replacing John Bowes, who is a non-voting member of the collaborative. And it's a pleasure to be here.
I'm Scott Kennedy. I'm the Chief Medical Officer and Safety Officer at Olympic Medical Center up on the Olympic Peninsula in Port Angeles. And we have a range of telemedicine in practice, kind of at a minor level, but also many other levels that we're very interested in.
All right, so all I was doing is just calling out folks' names who signed in to Zoom. If you are on the phone, all I can see is your phone number. So please, if you could just introduce yourself and who you're representing. I'm going to read off, first of all, a 360-236 number. That's you. Please.
That is Tracy Drake. I'm with the Department of Health.
Great, thanks, Tracy. And then we also have a 425-918 number.
This is Cheryl Huchala from Primera Blue Cross.
Hey, Cheryl. Next, we have a 503-415 number.
It's Lori Wakashige from Legacy Health.
Great, Lori. Glad you could join. I see Jody Kunkel. And Jody, could you just remind me which organization you're representing today?
Healthcare Authority.
Thanks, Jody. Next, we have a 206-685 number. You want to unmute yourself? That might be somewhere in the Seattle area. Okay.
Yeah, this is Sheila Greenchick, Washington State Health Information Management Association.
Thanks, Sheila. We have Sophie Dumit. Sophie, please unmute yourself and identify which organization you're working with.
I'm with the Dental Association.
Say that again. I didn't quite get it. Which organization?
The Dental Association.
Dental Association. Okay, fantastic. Stephanie Shushan. Unmute yourself.
Hi there. I'm from CHPW.
CHPW. Thank you, Stephanie. Anyone else I didn't call on? Okay.
Hey, John, this is Chris Gable with Kaiser Permanente, Washington. I couldn't get my computer audio to work, so I just dialed in by my phone.
Thanks, Chris. Yeah, I saw that you had signed in.
Okay.
Also saw Marcus Riccelli, Joel Fati, Sarah Orth are also on the line. Great. Well, I think what we'll do next is turn over to our hosts, and that's Jeff Clark and Josh Frank, just to tell the group a little bit about Confluence Health and especially what you guys are doing in telehealth, maybe some learning points.
Okay, want me to start?
Sure.
Okay. So Confluence is a rural health delivery organization that is integrated, has 2 hospitals, has 13 satellites, and we stretch a very broad geographic area going all the way to the Canadian border, over to Moses Lake, down to Royal City, and then up through the Wenatchee Valley. And so we actually have some very unique needs as covering such a large geographic area, and that is how do we how do we provide services for those patients across that large geographic area. In summertime is a lot easier than wintertime, and if we have our specialists on the road in stormy weather and snow and whatnot, it's not only difficult for projecting our specialists, but it's also a challenge for patients and also to get to us. So telehealth is actually just a perfect solution for us to be able to deliver services to patients in that broad geographic area. We have several initiatives, and I'll let Josh Frank detail that. He's put together a nice summary in that regard. But our efforts on telehealth have focused on a number of initiatives, and the one I just mentioned would be one of our swim lanes in that regard, and that's projecting specialty medicine. But we also have other initiatives related to primary care, supporting hospital care, supporting ED care remotely. We've also explored the direct-to-consumer option, and have spent some time at some organizations that are providing that nationally. We do run into the roadblocks that everybody else is running into, and that is the reimbursement piece associated with that. We'd like to do more in that regard. And when you think about the bending the cost curve in medicine, we see telemedicine as one of those innovations, or you call it disruptive, as Blake Christensen calls it, but one of those innovations that enables us to provide care, perhaps in a more cost-effective manner to patients. And so we have a governance that's been set up around this. We have, at least in one of our initiatives, and that's the projection of specialty medicine, we've actually, through project management, developed templates that enable us to more readily, if a particular department wants to deploy a solution, to actually have that ready-made. And these are the checklist items that we need to go over before we extend that. And it ranges anything from what workflows look like in departments, to facilities, to infrastructure, and also to compliance and to billing issues. And so to be able to take that template through governance and then apply it to a particular application is one of the steps that we've taken in developing our telemedicine approach. So, Josh, you want to detail some of the initiatives that you...
Sure, yeah, of course. And in general, it seems like the current state of utilization of telemedicine here is focusing initially on really real-time video encounters, is what everybody is trying to gear up for. And it started back in 2008 with the emergency department, I found, with Swedish Medical Center initially, actually, right before I came here. And then that continued till 2013 when we allied with University of Washington for the telestroke service through the emergency department. And that was really the first effort with telemedicine here locally. And since that time, it's kind of been like an arc of utilization, I'd say. Initially there wasn't a lot of utilization because the hardware was poor and the connections were poor. And then everything kind of came together to hardware got better, connections got better, and the need was there. However, then over time, the emergency physicians became more accustomed to evaluating acute stroke, treating it, more comfortable with it. So now we've really backed off utilizing it unless it's a really complex case. So the hardware is better, everything's better now, but now we don't use it as much because we've learned so much from the collaboration that we're more independent. But it's still very nice to have that higher level of care for the very complex cases. That's been our experience in the emergency department with that. In the emergency department, telepsychiatry is also something we have thought about. We haven't really seen a need in our department for it yet. But telepsychiatry services are something that our hospital system is using and have been since 2015. And my understanding that it's not a real cost benefit, but it is an access benefit. So when we need it, it's there. But if we can have on-site psychiatric services, that's more cost effective. So it's a balance of utilization and supplementation in that regard. However, I was actually surprised to find that our anticoagulation clinic probably is like one of the more robust utilizers of the medium of telemedicine, and they've been doing that for over 5 years. And they actually run whole days of clinics, which they serve places like Omak, Brewster, Tenasket, Ephrata, and Moses Lake with this. They use the established patient visit coding for that with the local modifier of Q3014. They have people on site that see them and help them with it, and they also can bill for doing finger sticks and things like that at the originating site. They have kind of a collaborative effort between pharmacists, mid-levels, and physicians. And so that kind of complicates things with the billing, is my understanding. It's a little unique there because they use pharmacists a lot. And I came to understand the pharmacists aren't recognized as providers. So they really do a lot of, I think, complementary, to be honest, work through telemedicine, which I don't know how that will be for long-term sustainability. It seems like finding a way to get people reimbursed when they do that work would be something that would be useful in the future because it's a very good service and it's very well received by the patients and very effective. Another thing that they have noticed is that not all insurance companies will pay for telemedicine services for anticoagulation services. They still provide them, but evidently when that happens, the patient gets a larger bill, is what I've come to understand, when the insurance company actually doesn't provide telemedicine services. So it's better for the patient then financially to actually come in person. But in reality, it's not better because they live up in Omak or Brewster. So once again, there's the disconnect between what's covered and what's best for the patient that we're all working through. Beyond that, some specialty services have started using it, and gastroenterology probably started about 1.5 years, it seems like. That was piloted, and in this past year, it's really geared up. A lot more people are using it. And they uniquely found it useful in OMAC, is my understanding, because they go up to that site, they do procedures, they do EGDs, colonoscopies, but if they have to do their new patient visits, then that inhibits their time that they can do procedures. So they're doing their new patient visits over telemedicine ahead of time. Then when they're on site, all they're doing is procedures, maximizing their time on site, which makes perfect sense. So when they do their visits, they wound up downcoding a lot, maybe like level 2, level 3s for their new patient visits, rather than what would probably be level 4s normally because of the physical exam limitations kind of inherent to telemedicine. But that is offset because they're doing more procedures when they're on site, so they're perfectly happy to take that variation.
Let me interject there. There's an interesting twist on this too, and when you're trying to pair up the provider expertise with the medium, we discovered something interesting in that the physicians did not feel that it was as efficient for them with the telemedicine visit because they were able to move through it very quickly. And so we deployed the advanced practice providers, actually, since they generally tend to be a little bit, take longer with their appointments, and paired that up and actually able to match that load. And they were able to do these new patient visits. And then that released the providers to actually be more have more slots for doing the procedures. And so we ended up increasing our throughput in terms of colonoscopies by 6 to 8 per week, which was really significant. So it's an interesting nuance when you start thinking about matching load leveling the provider's skill set to the medium that you're providing. So anyway, this is the
No, it's an important point. That was kind of one of the points of discussion I found out, because then moving on to cardiology. So cardiology has been using it for about a year, and they're doing really established patient visits. You know, they're not procedure based in these locations. Their cath lab here is here in Wenatchee, and so they're just really doing follow-up visits with these people, and that comes down to efficiency. Like if you're a cardiologist, you're doing a follow-up visit. And how do you initiate the visit and then you end the visit in a reasonable time frame? And I was talking to one of the physicians, about this, and he said, if he picks the right patients, if he picks, the right kind of disease processes present in these patients, and sets some boundaries ahead of time, then he can do a visit in a reasonable amount of time. If the boundaries aren't set ahead of time, it can be harder to end a visit, in a reasonable amount of time. So that's definitely something that providers and offices have to kind of get used to, as to what the right population is, and can they do a visit efficiently, a 10 to 15 minute telemedicine visit, or are they going to wind up spending a half an hour doing it, whereas in person they would be doing it in 10 to 15 minutes. So that's a lot of the learning curve on the part of the departments and the providers actually engaged, and the patients, to be honest, to be ready, to facilitate that kind of visit quickly. And the cardiologists, they're billing level 3s and level 4s pretty much regularly. So they're able to document and get enough done in that visit to get reimbursement, for that period of time they feel, and they feel it's enough of a value to the patients that they're willing to do it, and it seems to be growing in its utilization. One thing that they have found that's interesting that they noted to me is they were surprised by is how receptive elderly patients are to it, and how actually well they do, during a visit. So they found them a pretty good patient population to use in it that they didn't really expect as much.
Let me take another diversion.
Yeah.
Yeah. So just another diversion on the efficiency of the visit that's interesting is the deployment of carts. And so we did take a stab at that, and we had 2 use case scenarios, and one of them was in cardiology. And so that cart was going to be able to have a stethoscope attached to it, and so I can't remember. Vicki, do you remember what else it was? I think maybe there was an otoscope attached to it, but that wasn't really for the cardiologist. Yeah. And it turns out that the patient selection really, and the type of visit, just there wasn't any value add to having the cart as far as the cardiologists were concerned. The other thing that we ran into is when we tried to project the hospitalists to another hospital for coverage, is that most of the time when you're making decisions about the care of that patient and whatnot, it's really based on the history of what's happening with that patient in terms of whether they need transfer or whatever else is going to happen. And so that wasn't really working out. And so that each time the providers, one provider might have an opportunity to use that cart maybe once in 2 months. And so, sorry, Vic, go ahead.
I'm just going to inject the part also that is still an opportunity on the technology side, that cardiology, from the quality perspective, we're really not too thrilled with the technology. They felt like it wasn't quite advanced enough for them. So we still have that opportunity as an industry to help that technology be better for them. That was what they shared with me.
Good point. Yeah. So the fidelity actually of the sound coming through was just not felt to be sufficient to be satisfied that, well, okay, so that remote stethoscope gets on the patient's chest. Are we really hearing everything that we would hear if we were to take a stethoscope and actually put it on the patient? So it's kind of an interesting discovery in that regard. And so not only was it an issue with the actual technology, perhaps, but patient selection, and then I think sufficient use to gain that expertise with the technology to feel proficient with it. It's a sidebar.
Right.
That's very relevant. And neurology is also starting to use it very recently, about 6 months ago. Oh, yes.
On your sidebar, I'm sorry to interrupt. For, when you say patient selection, is it the referring provider that does the patient selection and maybe they load you up with inappropriate patients, or would it be the specialist that actually see, I mean, who's in that decision?
These are follow-up visits, so it's going to be the cardiologists themselves.
Okay.
Yeah.
Okay.
The only ones that are new patient visits right now are the gastroenterologists. That's pretty much in preparation for procedures, kind of what it's understood.
I want to, just one point of quick clarification, if I could. So as this patient selection idea, it's really important to figure out what's going to happen during that follow-up visit. Because what I hear you saying is that 15 minutes of a planned home visit actually, or 30 minutes of an unplanned home visit could be 15 minutes in the office. And so it really takes a lot of anticipation on behalf of the cardiologist to be thinking about, what am I probably going to encounter here? What does this look like? So it really is a judgment call on their behalf.
That's my understanding.
That's your understanding, yeah. Fair enough.
And maybe over time, the patients get better as well at knowing how to make use of that time.
Yeah, just wondering about the efficiency. Okay, thank you.
And I think, can I interject a little bit, of course? So on Confluence's journey, I think that what's interesting is we approached it as a steering committee that trying to not go down too many rabbit holes of people just finding sexy technology and then trying to find a use case for it. So learning from others who have been down this road quite a bit with telemedicine. So we started from that premise of what problem we were trying to solve. And at that time, the problem Confluence was trying to solve was what Dr. Clark described: specialist on a road, and sometimes in the winter, very, very dangerous. Patients on the road, very, very dangerous. But the part maybe that I would add to this as a COO that I've learned through advisory board and many other people is that trend happening where 30% of our patient population want to interact differently with us. So it's that consumer side that we know does start driving and demanding us to do things differently. So we're starting to head in that direction as well, while we still try to solve our own problems and some of our local patient problems. But we look forward to learning a whole lot more. We've made some good progress, but we certainly hope that the reimbursement can keep improving, seeing that overall impact of cost of care, convenience, the opportunity cost for us then to backfill it with people who do need an in-person visit. So just a win-win overall, but really challenging for everyone on that reimbursement side. Selling it to your CFO can be very challenging.
Can I ask one question about your reimbursement? So I'm assuming you guys are doing these visits in Oroville or Tonasket, where I would suspect those are RACs for rural health clinics.
Correct, they're rural health clinics.
And the payers are, especially the healthcare authority, I know they're sitting listening in. Are they giving you an encounter rate, or are you still kind of?
It is an encounter rate, just lower than your rural health encounter rate.
So they
quite a bit lower.
Okay, so they don't
quite a
match.
bit lower. And as long as the patient's at their rural health site, but the provider's at a different non-rural health site, then you can bill. But it is significantly less. And you know, we're just hoping that that'll start to improve and catch up. But in the meantime, it does help us on that opportunity cost in many circumstances to backfill and get other patients in. So there's the benefits for sure. And the patients have responded really well.
Great. Well, thanks so much. I mean, I really take away 4 themes. I think we're a little bit tight on time. We do.
I'll ask them.
Okay.
And anyone can send Dr. Frank an email if you guys have more questions. We'll be glad to answer them.
So I really heard 4 things. First is reimbursement continues to be a challenge in a variety of ways. Second is the pharmacists cannot bill for telemedicine.
Well, they can for non-Medicare, but not Medicare.
For Medicare.
They're recognized as a provider on non-Medicare side.
But Medicare is a full payer.
Yes, they are.
I heard the theme of workflow and making sure this works with the other care streams, and then technology matching that, and maybe not spending so much. Well, great. Representative Schmidt, did you want to follow up with a question for the team here?
Your encounter rate that's happening, is that through the MCOs? Is that where the basis of that?
No.
Managed care organization like Molina?
Um,
I'm trying to get an idea of
it's
who's
just through
determining that.
Yeah, I
rate.
guess I don't know who's, I think it's just individual payer.
We can answer that. I think our CFO answered that.
Yeah, so on a rural health clinic, that does come through, it's a cost-based reimbursement per encounter. And that's reset based on, it can be reset on any given number of factors, but it's cost-based set through the state.
So that means that's a Medicaid population, and this is the reimbursement rate that's being done by the MCOs.
They're paying it instead of the state.
Thank you for that clarification.
Great. So I think the next agenda item is just to review the minutes from May of 2019. So if you want to share those with folks, and those should also be on your attachments if you wanted to review those. In May we met in Vancouver, and Lori Wakashi shared some of her learnings at Legacy. We went over the ATA meeting and some of the highlights of that. We talked about Google Analytics.
Sorry to interrupt. John, I'm having a really hard time hearing you. I don't know if other people are also.
Thanks, sorry. How's this? All right. Can you hear me now?
Yes, much better. Thank you.
Okay, great. We have a little portable microphone.
Okay.
So we're just reviewing the minutes from May 2019. And we are going through some of the highlights of the 2019 legislative session. Some of the new laws that are coming in online.
I got one correction from Kara. The dates on, oops, sorry. Kara, I saw your email about the dates for the conference in Anchorage, and I'll make sure and adjust those in the final version.
Great, thank you.
All right, any other edits or comments on the minutes from May 2019?
No, other than that I was present by telephone.
Okay, all right, so Scott was present by telephone, thank you. All right, well, maybe if we can get a motion to approve the minutes. Do I have a second? Second by Josh. All in favor, please say aye.
Aye.
Anyone say no? Okay, we will post those. So the next agenda item is to hand it over to Lori Wakashi. So Lori participated in the Telehealth Association of Oregon's meeting, and she was just going to share what she learned at that conference in the last month. So Lori, do you want to just give us some highlights from that meeting? Lori, I don't think we have your audio. And Lori, I see that you're on, so. Okay, maybe if we can ask Nicole or Randy to contact her and see if we can get her online.
Dr. Scott, what name would she be under? Let me see if I can get her.
She's a 503 number, 503-415-5600.
Oh, I see.
Try that. Lori?
Hello?
There you go.
Yeah.
I just kept hearing you were muted and then you were unmuted. So can everyone hear me now?
Yes, go ahead.
Okay, perfect. Yes, so I'm a member of the Telehealth Alliance of Oregon, and currently we're a 12-member board in Oregon, and it's primarily a consortium of healthcare systems as well as some other organizations that are focused on telehealth, and we have some subcommittees that focus on policy, membership, and education. and we tried to put out some information to our broader membership as well. There's a website that we have, and we just had our conference in Portland back in May on the 13th and 14th. So most of the presentations are attached at the link under 2019, the 2019 summit. So that's who we are and what happened in Portland. And some of the highlights that I just wanted to share from our summit. We had Judy Murphy, who's the Chief Nursing Officer at IBM Global Healthcare, speak. And her presentation was really sort of comprehensive and enlightening about the direction of telehealth. She touched a little bit on the artificial intelligence component, Dr. Scott. I know there's some interest there. She also talked about utilization of telehealth services in terms of acute care in the hospitals, as well as virtual care in patients' homes. And then we also had an update on the Medicare rules and codes, and a little bit of the Medicaid updates as well from another speaker, and focused a lot on home monitoring, because I think for a lot of organizations in our state, that's where everyone's interest is focused, as well as the virtual care for services to patients in their homes over phones and other devices. So there's some updates on that presentation as well, specific to codes and services, and that's also on the website. And let's see, any other significant takeaways? OHSU actually did a really good presentation on home monitoring. They have 3 different programs going now, and we also did a panel discussion on, as a state, what kinds of efforts Oregon is going to be focusing on. We really want to look at the compact, the physician compact again. So we've had a little bit of resistance there from other organizations in the state, but want to continue to pursue that. And the discussion of parity came up briefly. So, so those were, I think, the bigger takeaways from a lot of the speakers there. But like I said, the PowerPoints are on our website. And there's also an effort, I think, in Oregon to expand broadband. So we had 2 bills passed, 2173 and 2184, to do that. And in particular, Senator Wyden here is interested in actually creating a national office for broadband. So I believe that was specific to 2173. Any questions?
Great, thanks, Lori. So the website you're referencing is the TAO website that has those talks and things like that?
It is, let's see here if I can, I think it's www.ortelehealth.org.
Okay, and are those publicly available?
They are.
Okay, great. We'll make sure that those are in the minutes and folks know about that. So when you reference Senator Wyden, is that a federal office that he's proposing?
It is. It sounds like it is. It's a national broadband office.
Okay. Other questions for Lori and what's going on in Oregon? Seems like there's a lot of overlap and similarities in what's going on in Oregon. And I think that it would be great if they could sign on to the Interstate Compact as well, because we, as you know, in Vancouver, there's a lot of patients who are going over the Columbia River there, and it can be very difficult to follow up with them. We see that also in Eastern Washington, people coming back and forth from Idaho and Washington. Yeah, Scott.
I'm wondering what's the concept behind the physician compact?
So the question was, what's the concept behind the physician compact? So this is the Interstate Compact law, of which Washington is a signatory. So you may recall, Scott, that to see a patient, you need to be licensed where the patient is at the time of the consultation. And that can, if I wanted to get a license in another state, that they have to check all my background. They need to check where I went to medical school, my residency. They have to verify that. That often takes about 6 months. And the concept of the compact is that instead of the Idaho and Montana doing that work themselves. They just simply would go to Washington State MQAC and get that information from Washington State. So it saves time. They're still collecting the fees, but it speeds it up from 6-month turnaround to, in our experience, about a month. The big thing that we've learned is you need to get fingerprinted to be a part of the Interstate Compact, and that's some of our physicians don't like to get fingerprinted. So. Are there questions for Lori? Okay. Well, great. So the next agenda item is the follow-up of the results from our telehealth patient survey. So this is related to the subcommittee on advocacy and advocation. So I'm just going to share my screen and give a brief talk, and then we'll talk about the Google Analytics in a bit. So this is a result of a survey that we did in the Puget Sound region. And I think that in general, we're seeing that patients are having a digital experience that is very focused on convenience and access. So many of you take advantage of Amazon, ordering books, food, clothes, everything, and in some cases can be on your doorstep within hours. Uber, if you need to get a ride, it's been a great help. Yelp gives you a great user experience and it's validated by many people. An example from Facebook is just how you have multiple ways to connect with people, and it creates a community. Netflix, the classic thing from Netflix is this: if you like this movie, you might like these other movies, and so you don't have to do a lot of searching. Starbucks provides a really consistent service and quality. And so those are examples just outside of the medical realm, but in the medical realm, we're seeing niche providers getting in here, like One Medical provides primary care. They do have integrated telehealth with that service. Health Grades is giving more transparency to healthcare, as well as good RX. Kaiser and work that Chris is doing has really moved the needle on connecting digitally with folks. And then organizations like Apple, Fitbit, Indigo are really making it much easier and more personalized for patients. So I think we're going to see many of these influences coming to bear on traditional healthcare. So we asked patients in the Puget Sound region, what do you want in your healthcare? The most important thing is the reputation of the provider with strong online reviews. People are going to the web first before they book an appointment. The second most important thing is access an appointment. They don't like waiting a long time. And the third is how far do I need to travel to get to that specialist. And then the fourth consideration is cost. So on the right-hand side of the screen is the top reasons for not following a physician referral. And the number one reason is that they already had a specialist in mind, maybe from a prior relationship or a family member. The second most common reason was a long ways to drive. And the third is just a long distance to travel. So pretty common across the board here. The other issue is that demographics matter. So if you are young and have children, you're more likely to use telehealth, with the sweet spot being really in that 35 to 44 age group, at least in King County. Nationally, we see a higher uptake of telehealth in the millennials, the 18 to 34-year-olds. And if you have children, you're way more likely to use telehealth, 66% versus 34% if you don't have children. And that's consistent in King County and nationally. The other issue is that demographics do matter. If the higher income and the fact that you had commercial insurance will make you more likely to use telehealth. So the income bracket of 50 to 100,000 seemed to be the sweet spot, with 39% in King County having used telehealth. And if you're in an HMO or a PPO, also much more likely to use telehealth. So some of the services that patients would like via telehealth, the most common situation is just a follow-up appointment. Those would be like follow-up from a surgery, primary care, and behavioral health or mental health as a follow-up. And some things would be like tracking your health status, blood pressure, following up at your home after you've maybe had an inpatient hospitalization, and just reminders to keeping a person healthy. So in terms of telehealth awareness, there's pretty good awareness. There's definitely more and more awareness of telehealth, especially in the younger consumers. So nationally, 27% of people said they'd never heard of telehealth, 36% had heard of it but didn't really know that much, and about 32% knew a little. So it's a little bit of a third. And when we looked at the Puget Sound region, it was probably better awareness than national survey from Accenture. So 61% of patients under the age of 55 had heard of telehealth, but only 39% over the age of 55 had heard about it. So some of the things that younger people might be interested in, and they're seeking out self-referrals for telehealth or women and children's needs, and then sports, spine, and orthopedics. So in general, older populations are less aware of telehealth, and so they really look to their providers as guiding them to initiate the use of telemedicine. So just a re-emphasis that there's an evolution in society to put technology at the center of our lives, with the smartphone being probably the key enabler of that. So I think there's a concern about what's called the digital divide and having broadband access. So if you look at nationally how many people have internet access, it's 89%. In King County, it's almost 100%, 98%. And then high bandwidth broadband, nationally there's 65% who have broadband, and in King County it's 81%. Smartphone penetration is quite high as well, 77% nationally and 88% in King County. So I think less and less there are fewer technological issues for getting telehealth. And lastly, I just want to wrap up with a survey that we did with providers. And I'm sorry, I just lost my presentation. Let me pull it back up here. So we surveyed over 200 providers in our system, and we had great awareness. 73% were aware of telemedicine, but they were not currently using. It was around 20% were aware and using. And their most common reasons for interest, fortunately, really match what patients were saying. That they're recognizing that this is a great convenience for patients. Their interest in new care models and being more efficient and reducing costs. So the majority of providers would like to do it for follow-up visits. Again, that matches what the patients are saying. And the concerns, at least at the UW, were clinical appropriateness, reimbursement, and physician capacity. So that's all I had for the survey of patients and providers. And I'd like to open it up for questions and comments, kind of dovetailing what we were talking about here at Confluence as well.
Is that survey available to the public?
No, it's not. Sorry.
Dr. Scott, this is Lori.
Yes,
I just had a quick question. The last three things that you mentioned, did you say that those were the provider concerns, the clinical appropriateness?
The last slide was a provider survey. So those were reimbursement, clinical appropriateness, and just the technology.
Okay, great.
And there's a question from Stephanie from CHPW to do this survey outside of King County. Stephanie, I know this is a survey that we sponsored at UW, and there's no plans for us, but there might be ways to do it through the Collaborative to put out a survey, maybe through WISMA or WISHA or maybe other avenues.
So,
We did commission a survey to ask that exact question. Does Eastern Washington look any different than Western Washington? And Vicki, I think we came up pretty much about the same conclusion in terms
Even
of.
as national.
Yeah, it really looked pretty similar, and we thought maybe it would be a little different for us because, our broadband penetration, especially up north, is not as great, and then we have a large Hispanic population, and we had interest in whether that was the language issue and how that would sort out. And so there are some nuances in the rural areas, but pretty similar results.
Yeah, it basically mirrored national in the West.
Yeah. So Vicki was just saying that the Confluence had done a survey of Central and Eastern Washington, and the results they got were very similar to national in terms of there being not a lot of knowledge, but interest once they are exposed to the concept.
Kind of showing that 30% adoption rate at this point on average is very common.
Yeah. So 30% adoption rate. Yeah. Okay. I'm wondering if we can dig into an idea of that folks are talking about doing a survey. There are ways to do this. I had mentioned WISH and WISMA, maybe the Nursing Association. Do you think this would be a worthwhile activity, or do you feel like the survey results are concordant between what Confluence is seeing and what the UW is seeing?
Does the state need more information?
I think it would probably bear out the same results, basically. I don't know if they gain a whole lot of different information. But we could share our survey results, which was 4 counties, 12,000 square miles, kind of compare and contrast, and
Okay.
we can do that.
That'd be nice if you could share that.
question set was a little bit
They
different
are
than what you
different
have.
questions.
We actually had some more specific questions relating to our initiatives.
So we had a little different question set as related to our initiatives, but we're more than happy to share those findings.
Great, thanks. Representative Schmick's shaking his head.
I don't know if that would really benefit. I still think we're going back really to something we discussed before, and that's reimbursement.
Yeah.
And consistency in reimbursement still is going to be the issue on take-up of the service. And one thing I picked up today is coordination of we're not really sure what the HCA is doing between the PEB and the Medicaid populations that we're responsible for. It'd be nice to know what consistencies. Frankly, it'd be nice to know what L&I is, as far as policy, so that it'd be nice to have some consistency.
So I just want to summarize for folks who may not have heard what Representative Schmick said. He feels like reimbursement is still the main sticking point, and having some consistency across the various payers and just having a little more transparency on that. Okay. Gotcha. Ray?
Ray Hanlon from Labor and Industries. We do have a reimbursement policy for telehealth medicine. One of the main sticking points for us right now is whether home origination actually is an important consideration, and how we're going to deal with that as a reimbursement policy. We're looking for the ability of to get some information from this group to try to set up those policies. But one of the main distinctions that we have with Labor and Industries is keeping that worker engaged and activated, and the relationship between employment and health. So it's really a slightly different nut to crack for us than it is for Medicaid and the Healthcare Authority for the PEB population. But we are definitely engaged. We want to move this forward. We're working on our policy, but we do currently have reimbursement, but not for home origination.
As with place of business, place of injury, it's not a clinical originating site. It's not a home. Is that another category, or would you just lump that in with home?
I'm sorry, I have trouble hearing. Could you repeat that a little louder?
The place of business, the place where the injury occurs,
right,
which is not a clinical originating site, and it's not the patient's home. Does that fall under the same category as a home originating site?
It does. And again, part of this is also, although we haven't addressed it too much, which is technology. Injured workers, probably 1 to 2% of any clinical population that most clinics see. We've got a large state without strong infrastructure in certain areas, as we were talking about up north. And so part of it, and injuries just happen. And then we have to deal with it. And of course, the most important thing for an injured worker is to get them to treatment and to keep them engaged with their employer. And those kinds of things have to happen in very rapid succession. So one of the questions that we have to address on the reimbursement side is, do we give everybody a cell phone? Is that one of the first things that happens? So those types of considerations, I'm not throwing a blanket on this, but the other part is also providers. So we're trying to keep up with the larger groups that are moving forward, but we've got some very different issues to set up in terms of the barriers to keep our workers engaged, make sure that the providers that are happy with what we're doing, and to make sure that we get them back to work, because return to work is one of the most important things.
Great. I don't think this Collaboratives knows that much about labor and industries and maybe some of the unique issues, especially when it comes to telemedicine. I'm wondering if in our next session we could learn a little bit more about that and learn a little bit more about your policy, first of all.
Absolutely.
Maybe how that might differ, and just kind of put out the table some of the challenges that you're facing. That would be really good.
I would love to have an opportunity to do that. Thank you.
And Vicki?
And I would wonder if there are other states we could learn from on the LNI that might have progressed this further.
Sure. We're talking about workers' comp. I won't take too long on this, but one of the things that's somewhat unique about the state of Washington, we have a monopoly. And in other states, we have commercial insurers that, and the philosophy of those two groups, depending on who you talk to, can sometimes be very different. There are 3 or 4 other states that have very similar monopolies to what we have. But the orientation of keeping the worker activated, getting them back to work, those types of considerations are somewhat unique to the state of Washington. But we are very interested in telemedicine and telehealth, and we want to get, one of the most important things we do is make sure our providers are taking our patients, because they often are very difficult, and we want to get access. That's one of the most important things we want. We want to keep the worker engaged. Those are the 2 main considerations. So that's what we're working towards. And I'd love to have an opportunity to talk a little bit about it also. We can discuss that.
Great. Thanks, Ray. Other questions or comments about the patient awareness and provider willingness? Scott, yeah?
Was it able to look at the use of telemedicine by various races in that area? In other words, access to telemedicine for subcommunities?
Yeah. So Scott's question was, was there a racial difference in uptake? And similar to the income levels, you do see a disparity by racial groups. So Caucasians have the highest use, followed by Asians, and then you do see Latinos and African Americans, and folks who are from African countries have probably the lowest utilization. I'm not sure if that's a reflection of language barriers or something else. But unfortunately, like a lot of things in medicine, there are not equal distribution of those resources.
It may also be a reflection of just access to care in Washington State, because I recently came across a survey that said that African Americans in Washington State just don't have the same access to care. So it may not be specific to telemedicine, it may just be healthcare in general.
It might raise the question of using interpreters with telemedicine, that layer and that potential challenge.
So Scott was saying, well, maybe the added barrier of getting a third party interpreter might add a barrier. I can speak anecdotally that we do have a high-risk OB program down in Yakima, where about 90% of the women are Spanish speaking, and we have not had an issue of getting an interpreter on the line. I was always able to do that. But when you have that many who are not English speaking, you've got to build it in your workflow. I think if it's maybe 10 or 20%, not that frequent, then that's probably where it becomes more of a barrier, especially unusual languages as well.
Hey, this is Brody DeChinko. Apologize, I I'm really late for this. I wasn't in the original roll call. Just from an added point that from our vendor usage of telehealth, the usage of bringing in an interpreter or a translation service is less than 0.1%. So it's extremely infrequently used, even though it's available.
I was just going to, Vicki Noyes, I was just going to comment that one of the things Confluence Health found around the Latino population that's separate from telehealth, but back to the access to healthcare that we found to be the greatest benefit and probably the best thing we could have done, we should have done earlier, is back to meeting people when they want to meet us. And so for the migrant workers, we realized they are not going to come out of fields to go to a doctor appointment, not for any reason. So we changed the hours of operation of the clinic. Okay, so when you're done at 7 p.m., would you come? Yes, they will. So that was kind of meeting people at their needs versus trying to force them into our healthcare box.
Yeah, I just want to make sure everyone heard Vicki's comment, because Wenatchee here is a large agricultural region, has a lot of Latinos, and they're in the fields to late hours, especially this time of year. And what they're doing in Confluence is they just change the hours of the clinic. But my question for you, Vicki, is have you ever thought about having telemedicine clinics into the fields, or
yeah,
you have thought about
that. We thought about that when we were looking at a mobile unit. So yes, we're trying to get creative, and a lot of those individuals are only here seasonally, and so puts another challenge to us to manage their care when they're not here all year. But yeah, we're looking at mobile units. We're trying to figure out, we do have on-site employer clinics also at the Stemilt Manufacturing Group company. We put a clinic on site. That has helped all their employees and families greatly.
Wow, that's really exciting. It seems like there might be a little bit of an opportunity to educate folks on maybe best practices around using interpreters for telemedicine. Maybe as an action item, Nicole and I can see if there's any articles related to how to use interpreters, and maybe we can follow up with some of the payers to see if there's wrinkles in reimbursement when you're using interpreters that way. Does that sound like a good idea? People would like to learn a little bit more about that? Yeah, and Ray?
I just want to say that for labor and industry, statewide, we have about 700 encounters per day that use an interpreter that we pay for, and about 1 out of 10 of the injured workers that we treat require interpreter services. So it's growing.
Yeah, 1 out of 10. So
1 in 10, yeah. So we're very interested in the topic.
Yeah, so much greater than what Brody was saying, almost 10%. Okay. Great. Any other comments or questions about the survey results? Okay, well, so the next agenda item is follow up on the Google Analytics data. So I think I had sent around the whole year summary previously, and just to summarize that there are around 2,000 total visits to the WISHA website. And I think there were some follow-up questions if we could see where people were clicking on the WISHA website, and we don't have that level of specificity to know which documents they're collecting. We do know what cities they're coming from, and they tend to be pretty much in the I-5 corridor, quite a bit from Olympia, the Seattle area, but I'd say there was good representation in the Spokane, Vancouver, also in the Wenatchee, Ellensburg area as well. So I think it is reaching all over the state, and I just want to see if there's any follow-up questions about the website performance and Google Analytic data. Okay, so we're going to move on then to the next agenda item, the report from the subcommittees, starting with research and then payment model advocacy and education. So I'm going to give a summary from Chad Gadelin, who was on a plane and couldn't join us today, but he did give me an email summary. And so many of you know that he works at Virginia Mason and the Ben Arroyo Research Institute. Is part of Virginia Mason, and they do have the potential to help with population level studies with statistics, epidemiologic studies. And so if you're interested, that is a resource to do more research. Sarah, did you want to say anything more about the research, some initiatives or things you're thinking about? Just make sure you're unmuted, Sarah. Or Randy, if you can help unmute Sarah.
Stand by. Let me see what I can find.
Okay.
Thanks. It said I was muted by the host.
Okay, you are unmuted by the host. Go ahead, Sarah.
So we had talked about this group, I think 2 or 3 meetings ago, and the intent was to gather some people to develop some guidelines around what telehealth research should look like. I wanted to see if people were still interested in that, and Dr. Scott, you mentioned you would be interested in that group, but would we be having subcommittee meetings, or what would the logistics and stuff look like for these subgroups, or is it intended to be less formal?
And so I think just to give you an idea of what other states have done, they have statewide collaboratives, and they've used that form to look at things like the surveys. They've used it to look at the value of telemedicine. So they've looked at like cost effectiveness analyses in particular use cases. So I know that continues to be a question about the value of telemedicine. And that's where kind of was angling that this research group might be valuable. And I'm willing to meet with Sarah and Chad and others to see if we want to meet before our next collaborative meeting and talk about ideas and come back to the larger group with some ideas.
That sounds great. Thanks.
But is there anyone else who is interested in the research idea?
I would be interested, Dr. Scott. This is Lori.
Okay, Lori Wakashige and also Kathleen Damon, that's Swedish. So, and if you're shy, you can also contact me offline. Joel also, okay, Joel Fati.
John, question for you on the foci of research topics. And one that came to mind to me is cost avoidance and what that looks like in organizations, both internally and then in the L&I setting. So what actually are we able to achieve in cost avoidance by use of this technology?
That's a great idea. So I'm working with a PhD student currently in health services research who's looking at this, the use of the urgent care clinics. Those are almost publishable, so I might be able to share them next time, providing they're accepted. So, Scott?
I don't know if anyone's looked at this, but it might be interesting, particularly with the rural areas, to look at readmission, what effect telemedicine has on readmission, if it does.
Yeah, Scott was saying readmission might be an interesting research question, and can telemedicine prevent those? Okay. Right. Cartel also is interested in research. Okay, so maybe next we can move on to talking about advocacy and education. And Kathleen, I think you had a paper or a presentation that you wanted to share with us. So I'm going to turn it over to you. And Randy, if you could please unmute Kathleen Damon, that'd be great.
Great, thank you. I'm going to share a screen if I may. So I am borrowing a presentation from Jose Good, who's one of the nocturnists at Swedish. And he put together a program and wrote a paper as well. And I'm happy to share. I have a couple different things that I can share. I've received approval from different folks that I can share this with you. So we started a telehospitalist program in, let's see the data, let me double check. Let me just I'll run through his PowerPoint just kind of quickly. This particular program was looking at providing nocturnal support for our Ballard campus. So Swedish has 5 hospitals, 7 EDs. One of the hospitals has a relatively low nighttime admit rate, and to provide hospitals there full time didn't really make sense. We looked at potentially having a nocturnist call in for admits, so we didn't have to wait till the morning admit. Doc would have a big caseload to take care of first thing in the morning, so we provided nocturnal support for the admits at night. And Jose was looking at this particular pilot. You can see that I showed what are the metrics of that. We're looking at diagnostic accuracy, length of stay, and patient satisfaction. We had during that time period, there were over 500 consults. What I wanted to point out and what I brought up at the last meeting was the 99.1% diagnostic accuracy. What we were looking at was looking, as it notes here, is the admission diagnosis with the DC diagnosis. How close were they and what were the differences? And the one that was missed was due to cellulitis. We had a handheld camera that was being used, and the focusing was a little funky and a little wonky. We had the nursing soups as the telepresenter on the patient side, supporting the physician. So we trained the telehealth program, trained the nursing soups into doing a full head-to-toe physical assessment underneath the direction of the physician. So they were practicing within scope. These were some of the other clinical measures that we looked at. The readmission, so that was just brought up. How many readmissions occurred after the discharge, and just the variety of the pieces. Let's see, the length of stay. You can also see the results there. Patient satisfaction, also very high. Had specific questions, and I can have more data to that. So it gives you the time frame, diagnostic, etc. And then Jose was in a PhD program at the time, and he was at OHSU, did provide a paper. This is online, so you can get it online if you want to read through his specific information. One of the things we were really looking at, does it make sense? So with this particular, let's see, let me move this. There we are. So I'm happy to share this as well. This was a pilot program, and it was a pilot for Providence St. Joseph's Health, and which is the old Providence and kind of expanded to accommodate a variety of other health systems. This program is now live in 7 hospitals, a couple in Oregon, a couple in Washington, mostly nocturnal support, specifically on our critical access hospitals, a couple on the coast in Oregon. Seaside is one of them, so really don't have nocturnal support. So providing the support at that hospital, and now we've also involved not only ADMET, but also cross coverage. It is expanding, and especially for hospitals who don't have access to the hospitals and don't want to pay for somebody at nighttime. This has really been a great asset. That was the one piece I wanted to share. The second piece is for advocacy, and Denny Lorden is, we have actually Swedish telehealth department has been, I say, hoovered up, but absorbed into Providence St. Joseph's Telehealth, and now I'm a Providence St. Joseph employee, not Swedish, in the same spot, basically upstairs, but we have an all-hands meeting here on campus, so Denny is participating in that while I jumped out to participate here. Denny is part of the advocacy for Providence St. Joseph's Health, and participated in a CTEL White House meeting on Friday, June 14th, which I'm sharing a little bit of info there. The CTEL is the Center for Telehealth and eHealth Law, of which he is a participant or a member. They went and had a conversation with Congress, with specific delegates from Congress, and had a couple of directives that they provided. So he has 2 things. I'm just going to briefly share those with you. They directed number one here, I want to just point out, CMS to conduct cost impact studies within Medicare and Medicaid, something that I know was near and dear to our hearts. Also to promote legislation removing Medicare originating sites in rural area restrictions, another thing that really has a big impact on CMS reimbursement. And then the third piece was to include telehealth in the executive order to expand high deductible coverage for chronic conditions, specifically for congestive heart failure, diabetes, renal failure, etc. The second piece, and I know I'm kind of flying through this, but I want to make sure I don't take too much time. This last piece was this was specific from PSJH. This was asking congressional delegates to, number one, become co-sponsors of the Connect for Telehealth or for Health Act. And I highlighted the 3 areas specifically that they wanted them to address, which include to expand allowable originating sites to non-rural areas. The only ones were recently, let's see, current law permits only CMS to pay for telehealth services, as we well know, for patients located in rural locations. Also to expand the telebehavioral health services, as we well know, telepsych is a huge need in all areas. Specifically, that is to remove the geographic site requirements and also to allow patients home as an eligible originating site. And then to our comment earlier with regard to pharmacists and other providers, to include physical therapists, occupational therapists, speech, language, pathology, and genetic counselors. So these were some of the specific areas that we were requesting. Also asking congressional members to join a congressional telehealth caucus and or to visit a telehealth facility in your district and state. So they had some really good conversations. Again, I just kind of whipped through these really quick, but I wanted to share what we have, and I'm happy to take any questions.
Great, thanks Kathleen. I just wanted to follow up on some of the federal legislation and just let you know that Representative Delbene from the 1st Congressional District has introduced a federal bill that would relax the rural requirement and the not being in home requirement for Medicare related to behavioral health or mental health issues. So I think that would be a great step in the right direction. So if you want to reach out to your federal legislators and let them know that this might be a good bill to support, that also help things out. Let's see if there's any other questions for Kathleen. Shared a lot about the telehospice to home, showing the value of that, and then also some of the advocacy issues that are going on. The University of Washington is also part of CTEL. I was not able to make this meeting, but was in DC earlier this month. And I think as a state, we're probably one of the biggest supporters of telemedicine. Both of our senators are big supporters. A number of our representatives have signed on to telehealth bills in the past. So I think we do have a good track record, and I encourage you to keep reaching out to your congressional representatives.
John, I did receive, if you don't mind, I did receive approval. If anyone wants to copies of these things, I did receive approval for everyone to share. So if that's something folks would like to read, I know I like to have things in front of me, so I'm happy to share as well.
Great, that'd be great if you could share those. Yeah.
Just a specific question for you on the Swedish initiative. Was there a device integration for carts?
Device integration, you mean for peripherals or for handheld devices like a Bluetooth stethoscope, etc.?
Like
yes.
Stethoscopes.
Yes. We had a Bluetooth stethoscope. It was a Littman 500. It was 500. Going back to the earlier commentary regarding the cardiologists, our neurologists are happy. The cardiologists are not as happy with the stethoscopes. But for listening to basic lung sounds, carotids, abdominal, they felt that it was adequate.
Great. Thanks so much, Kathleen. Other questions for Kathleen? All right. So I'm not sure I'm going to have time to talk about AI. I will come back to that next time. There are 3 articles that are pretty short, they're 1 or 2 pages. Feel free to read those in the interim, and we'll come back to some of the legal and ethical issues on that next time. I do want to talk about one other action item from last time. Representative Schmick, you had asked about getting specific languages around the telehealth training. So we do have a document that we've drafted for you to review. And this is also a follow-up item that the telehealth training, the slides are available. If you wanted to get credit, like CME credit, and show that you're certified, then the Washington State Nursing Association web link is there. It's $25. But then there's also just a public option. This wouldn't necessarily certify that you've gotten training, but if you just want to just make sure, hey, this best practices, it's the same slide set. It just the former is we need to have a way to track it, and there's a survey or a question and answer on that one. So I just wanted to particularly call out Sarah Orth and Joelle Fathi, who were the ones who helped put those together, and Sarah in particular was the narrator of it. So thanks very much to those two. Anything, Sarah or Joelle, you want to say about those trainings? Okay.
Muted.
Yeah, go ahead, Sarah.
Can you hear me now?
Yeah, go ahead.
Oh, thank you. Yeah, I would just say that it was a lot of help from everybody. This is a collaborative effort, so thank you so much. And really get the link out there if you have any staff or other people who are interested in learning what is telemedicine in the state of Washington and what are the requirements to get started. It's a really great resource and has a ton of links. So let's get those website hits up.
And
this is Joelle, just quickly. So just to be clear, it's not an actual certified module, but you can get credit for 1 hour of participation. So if you're looking to get credit in regards to continuing education or want to demonstrate that you went through that module, then the WSNA site does have that $25 1 hour pre-post test, and then a certificate that demonstrates that you participated.
Great, thanks, Joelle. One other thing I just want to come back to, and I know Representative Riccioli was having a little bit of problems joining by audio, is that he had sent out some information by email about the Interstate Compact. So if you have other questions, particularly Scott, please look in your email for that information. So at this time, we have about 10 minutes left. I wanted to open up for public comments and questions. We have members from the non-allopathic medicine on this call and in this meeting today, members of the Dental Association, optometry, I always want to say ophthalmology, optometry. So it might be good to hear from you guys, any particular questions or comments that you have.
Well, I wasn't expecting this, but thank you. I would say that, first of all, we're here because we've been following what is happening with this group. And in some alternative ways, we have been involved with what is going on. I don't think that our particular issues are so much as reimbursement as maybe some of the other issues are. Our issues that we are trying to address is quality of care. And we have some major concerns within eye care, that there are quality of care things going on that we don't feel are adequate. And we have documentation of this. And so we're here to learn from you what you're trying to do, to get suggestions from you, and perhaps we can give also suggestions with regard to how we feel quality control might be addressed. So that's all I want to say at this point in time. So it's a learning curve for us, and we thank you very much for this first opportunity to be here, and we would like to participate more.
Great, thank you. Any other comments? So I just want to make sure everyone heard that, our colleagues from the optometry community have said that there are some real concerns about quality of care. They've observed some some misdiagnoses, it sounds like, and just wondering if there are activities around QI that this collaborative has taken up. I can just speak that from my organization that we have internal QI. We don't police other people. I think that a lot of that policing is done at the licensing level. So for physicians, it'd be at MQAC. If there's any concerns about doing things that are not safe for patients, that's where the enforcement is done. So I don't know if there's anyone else has any comments about QI and as it relates to telemedicine. Josh, how do you review telemedicine QI? Is that part of your larger QI process, or do you have a formal way?
In the emergency department, if we use telemedicine in the emergency department, it's just part of the case in general. There's no separation whatsoever. I don't know how cardiology and gastroenterology, the other departments would do it. But I remember we had this discussion like last year regarding oversight, and it seemed that the input was generally that if there was anything to be investigated, MQAC would do it. And they reported that they hadn't received any case referrals at that point in time. They have one now. Okay, got it.
It seems like, sorry to interrupt, this bill sort of addresses part of that, in that this bill that Senator Schmick is involved with, or sorry, Representative Schmick is involved with, does kind of provide some kind of framework for training of providers, or in some sort of way allows for some kind of credentialing of providers that will be involved with telehealth. And that seems to address, it seems to me that addresses a lot of our concerns. But yeah, basically we're here because we understand eye care is the way of the future. It's going to be here. And I think we want to be involved with the conversation about how it should be done and how it may be done. So thank you.
Other questions or comments?
Just a comment on PACS integration. So as ophthalmology is progressing to obtaining those images, then the ability to actually put those into picture archiving systems and to move those around the state to enhance quality, there's some real opportunities there.
Yeah. Imaging is very important in eye care, and imaging is getting much better. Yeah, eye care. So.
Okay. Let's see if there's any other questions from the phones or from Zoom. And I know there's issues with being unmuted, so if you want to send a request to chat, we can do that as well. So while people are thinking about maybe some last questions, the housekeeping things, our next scheduled meeting is for the end of August. I think it was originally scheduled for August 23rd. We do not, is that right, Nicole? Okay. So we do not have a host for that. I'm looking in particular for someone maybe back in the Puget Sound region who would be able to host us. We have a pretty good mobile solution now that we've kind of got a conference in a box. And so don't feel shy. We basically just need good Wi-Fi.
You don't need the big fancy
Yeah,
setup.
you do not need a fancy setup. A quiet room and good Wi-Fi are the main requirements. A couple other things in terms of housekeeping. We referenced the ATA, the NRTRC, that's the Northwest Regional Telehealth Resource Center. That's going to be in Anchorage, and it's August 26th through 28th, so that's a Wednesday through a Friday. The conference registration fees are pretty modest. They're anywhere from $130 for a student all the way up to the full package of $290, and most people probably pay around $200. It's at the Sheraton, which is about $200 a night. And it's in particular for people who are maybe just getting started out in telehealth. There's a seminar on the first day that has really kind of telehealth 101. So this might be really useful for folks, and that's a great time of year to be up in Alaska. So let's see if there's any other questions or, oh, I'm getting corrected by Cara. I got the date wrong again. August 28th through 30th. So not the 26th through the 30th, 28th through 30th. It is a Wednesday through Friday. Great. All right, and if we can unmute Kathleen. Sarah said she's going to be giving a update at the NRTRC on our collaborative work. So thanks for representing us, Sarah. Kathleen, do you want to
Yeah,
chime in
just,
here?
yeah, just want to give a quick, PSGH was supposed to be hosting in February during our wonderful weather occurrence, our snowmageddon. So we'd be happy to host in, at the end of August if you just give us a ring.
Great. So we'll see if we can coordinate with Kathleen, the folks at Swedish, to have our next meeting. All right. Any other questions or comments? So I think we have a couple of follow-up items. We'll look forward to hearing a little bit more from Ray about LNI. We'll talk about interpreters and use of telemedicine. We'll put on the agenda AI, and hopefully we'll have a little bit more updates from the subcommittees. So, and if you have any other agenda items or things you would like to add, please contact me, Representative Schmidt.
I'd like to know how the Healthcare Authority, their policies surrounding telemedicine also.
Okay. So if there's anyone from the Healthcare Authority on the call today, there's been a request from Representative Schmidt to learn a little bit more about your policies around telemedicine. And if there's not, Representative Schmidt and I will try to find the proper people to get on the phone call in August. Okay. All right. Well, we want to thank our hosts again from Confluence for just a great reception, and congratulations on all your work in telehealth. And everyone have a safe drive home.